Thank you very much for allowing us to present this paper. We have no disclosures. Although the first laparoscopic colectomy was described more than 20 years ago, this technique was not universally accepted because many issues, because of oncological efficacy, because it requires advanced laparoscopic skills with a steep learning curve, and because of its initial increased costs. Furthermore, we should ask ourselves some questions. Who must learn and who must teach this technique? Regarding this issue, Sage's position paper, published in 1998, integrate advanced laparoscopic surgery into general surgery residency training. As you can see in this table, many papers have been published regarding this issue, comparing staff and resident surgeries in colorectal surgery. The first of them, published more than 10 years ago, didn't find any difference in operative time, conversion, and hospital stay. In the second one, published 2 years later, Mehal could find that operative time was prolonged in surgeries performed by residents, and in the last one, conversion rate and operative time was prolonged in the resident group. So the aim of our study was to evaluate the safety of laparoscopic colorectal surgery training in general surgery residents and colorectal fellows. We performed a retrospective comparative study based in a prospective database from 12-year period, and we included elective laparoscopic resection, right and left colectomies, performed by benign or malignant disease, and the exclusion criteria was applied for complex procedures such as rectal disease, proctocolectomies, or combined procedures. 3 groups were performed. In G1, we included the surgeries performed by colorectal staff. In G2, colorectal fellows, and in G3, general surgery residents. We analyzed demographic data, operative time, conversion rate, bowel recovery parameters, hospital stay, morbidity, and mortality. We analyzed the categorical variables by a chi-square test and the continuous variables by the test of ANOVA. From a total of more than 1,000 laparoscopic colorectal procedures, 619 colonic resections met the inclusion criteria. Most of them were left colectomies that represent 68%, and the others were right colectomies. From a total of surgeries performed in G1 of 332 of the colorectal staff, the average surgeries performed per group were 166 in G1, 11.6 in G2, that is the group of the colorectal fellows, and 13.6 in G3 of the residency of the general residence training program. When we analyzed the demographic data, we didn't find any difference between age, gender, body mass index, ASA status, and previous abdominal surgeries. We couldn't find any difference between the indication of the surgery or the disease that motivates the surgery. And we didn't find any difference between the operative time in the 3 groups and the bowel parameters, recovery parameters, such as bowel sounds, gases, liquid, and solid diet. We couldn't find any difference in the hospital stay between the 3 groups, but we noticed an increased conversion rate in G1, those surgeries performed by colorectal staff surgeons, when we compared it with the other 2 groups. When we analyzed intraoperative complications, we couldn't find any difference between the 3 groups. When we tried to analyze the postoperative complications, we used the Dindor-Clavin classification, and we noted that a little decreased complication rate in G1 was noticed, but with no difference regarding the most important complications, such as grade 3 or 4. We didn't find any difference between mortality in the 3 groups. So we can conclude that residents and fellows can perform laparoscopic colorectal surgery safely under supervision. Thank you very much.
Thank you for staying on time. It's open for discussion.
Nice presentation. Orkin from Chicago. I find it rather disturbing that in certain of your result parameters, the colorectal staff surgeons seem to do worse than everybody else. How do you explain that?
Yes. The day before the surgery, we decide who will perform the surgery between the colorectal staff, fellows or general resident training program, and we decide, although the statistical analysis didn't evidence any difference between these parameters, the disease and all that, we think that with a bigger sample size, we could identify some other factors that will motivate that.
So it's selection bias.
Yes.
Yes, and one other group that you didn't include were general surgeons, staff surgeons doing resections.
Yes, that's true.
Is that because you didn't have any, or you didn't want to look at that?
No, we have very, very little surgery performed by general surgery surgeons.
Well, working at a university institution, it's comforting to know that the cases that I give away have the same result as the cases that I do myself. But the truth is that that selection process is made at the time of surgery. I mean, so I've done, close to 1,500 laparoscopic colectomies, and also you don't define whether or not you're talking about things that are done intracorporeally versus things that are done laparoscopic assisted, because I think that's a huge variable in terms of how competent the trainee is to allow them to go on to do other things. But saying that, I mean, we all know that when you stick in the scope and you see a diverticulitis, there is diverticulitis and there is diverticulitis. Yes. I mean, it just depends. But it's still wonderful to see that the teachers, all of us who teach, we're not putting our patients at increased risk, and we know that for a long period of time, but it's nice to see it in print.
Thank you very much.
Tell Nicholas that we are indebted to him, because the documentation that you provided can be very helpful in certain situations, if you understand what I mean.
Yeah, okay, thank you very much.
Thank you.
Any other questions? Okay, thank you very much. Sure.